this presentation, the 10 Commandments of Neonatal Mechanical Ventilation, was not actually mine, but a good friend of mine, Professor Jan Mazella from Poznan in Poland, who, after he heard the talk, said I should retitle it The 10 Commandments. Now, I'm not going to try to convince you that I can part the Red Sea like Moses did, but I think that I have a very strong message in this talk that I would like to share with each of you. So my objectives will be to briefly review the components of mechanical ventilation. I will discuss the options for choosing the initial ventilator settings based on individual pathophysiology, and that's really my main message. And I will try to outline strategies for weaning from mechanical ventilation. Now, when I started as a pediatric resident way back in the dark ages, the middle 1970s, mechanical ventilation was really very easy, and we practiced one size fits all. It almost didn't matter what the baby's respiratory disease was, and the reason for this, of course, was we had very limited options in terms of equipment. Some of you may actually recognize this. This is the baby bird ventilator. This was introduced into clinical practice in the 1970s. And as I've traveled around the world, these machines actually are still in use in various places. They were extremely reliable. They had very few moving parts. The maintenance was rather simple. And when we had a baby who required mechanical ventilation, what we did was to set the flow rate in the circuit at 8 to 10 liters per minute. We set the peak pressure at 20. We set the end expiratory pressure at 4. And depending where you lived, on the other side of the Atlantic Ocean, we used relatively short inspiratory times of 0.3 or 0.4 seconds. And if you practiced in the UK or Western Europe, you tended to favor a much longer inspiratory time of 1 second. And it didn't matter, as I said, what disease the baby had. These were the ventilator settings that were used in almost all cases. And we hoped for the best. Now, when I say it didn't matter what disease the baby had, I think you can all appreciate that there are very significant pathophysiologic differences between our small preterm baby with respiratory distress syndrome, a disease of low lung volume, compared to a term baby with meconium aspiration syndrome, whose pathophysiology is just the opposite, where we have hyperexpansion and increased lung volumes. So if we treat both of these babies the same way, we're doing a disservice to at least one of them. And again, I think you can all appreciate that when you look at a typical X-ray. Here again, we're dealing with consolidation and very low lung volumes. Over here, we're dealing with hyperinflation and a different set of pathophysiologic features. And I think now, 50 years later, we have finally concluded that one size no longer fits the whole population. Each baby is different, each disease is different, and our strategies to treat each of these babies also needs to be different. I had the good fortune last year to travel to Hong Kong, where I learned a very interesting term, and I apologize, I don't know if this can translate into Ukrainian, but when you go to Hong Kong, you can have a very interesting experience by having a custom-made suit or a custom-made dress. And that's very different than when you go into a department store and you buy a piece of clothing off the rack, as we say, and these pieces of clothing may not fit exactly right. The sleeves might be too long, the legs might be too short, the waist may be too snug, But when you go into a tailor shop and you ask for a custom-made suit, everything fits perfectly. And the Chinese call this bespoke. And I think now we live in the age of bespoke ventilation. And you'll see this, I hope, as we go through the rest of the presentation. Now, I'm going to talk primarily about optimizing mechanical ventilation by how we choose the initial settings when we place a baby on a mechanical ventilator. And let me illustrate this by presenting a brief patient that you all probably have encountered in your everyday clinical practice. And this baby was born at 25 weeks gestation, weighing 720 grams. Mother was a 17-year-old prima gravida. She developed severe preeclampsia, which the obstetricians treated with high-dose magnesium sulfate, but they were unable to control her blood pressure, and after only one dose of betamethasone, Mom underwent an emergent cesarean section. The baby had APGAR scores of 2 at 1 minute for a good heart rate, and with resuscitation, at 5 minutes of age, the heart rate was still good at 140. The baby's color was pink with assisted ventilation, but the baby remained hypotonic, had no respiratory effort, and only a minimal grimace. The initial evaluation of the baby is described on this slide. You can see that the first arterial blood gas was really not that bad. The pH was 7.21. The PCO2 was elevated at 55 or 7.3 kilopascals. The oxygenation was borderline at 47 and 6.3. The baby's initial hemoglobin and hematocrit were appropriate for the gestational age, as was the baby's blood pressure. But you'll notice there is a biochemical abnormality that the cord blood magnesium level was 5.5, obviously in response to the treatment that was given to the mother for her severe preeclampsia. Now, my first rule, and I'll actually call this a recommendation rather than a rule, is try to define the pathophysiology. What's wrong with the baby? Why are the blood gases abnormal? And what can I do to help correct the situation? So the algorithm that I use in my mind as I go to the bedside and I evaluate this baby is the following. Number one, what are the lung volumes like? And again, if you think about the comparison between the small baby with RDS and the large baby with meconium aspiration syndrome, am I dealing with a low lung volume problem or a high lung volume problem? And clearly you saw the x-ray for this baby. We're dealing right now with a baby who has inadequate lung expansion and very low lung volumes. Secondly, what are the mechanical properties of the lung? And I asked myself, what is the baby's pulmonary compliance? And remember that compliance refers to how much of a change in volume you get when you increase the amount of pressure. So if the compliance is low, the lungs are going to feel stiff. If the compliance is high, it will be very easy to see chest expansion when you apply positive pressure ventilation. Now, fortunately, you don't need a machine or a device to help you determine pulmonary compliance. And the very best way you can do that is to feel the stiffness of those lungs when you apply positive pressure with a bag and a mask or a bag and an endotracheal tube. And if the baby's lungs feel stiff, then you know that your compliance is low, and you're probably going to have to use higher than an ordinary amount of pressure in order to move gas in and out of those lungs. Secondly, what is the resistance? Now this is an easy one because if you've got a small baby, and particularly if you have placed a small internal diameter endotracheal tube, you know that the baby's resistance is going to be very high. And again, you can feel this when you manually ventilate a baby through that small endotracheal tube. And having made an estimation of both compliance and resistance, it gives us information about the respiratory or the pulmonary time constant. And this is something that people don't always pay attention to, and I will show you in a few slides why this is so important. But the time constant is the product of compliance and resistance. And what it refers to is how long it takes for a pressure or a volume equilibration. And so if you think about this small preterm baby with RDS, if this baby were able to breathe spontaneously, how would this baby breathe on the first day of life? Well, the time constant for this baby is going to be relatively short. So the baby will take very shallow, very rapid breaths. As compliance improves, the baby will slow his own respiratory rate, take deeper breaths, and have larger tidal volumes. And we need to pay attention to this when we set our ventilator to cycle and when we choose an inspiratory time. And we'll go into that in a little bit further. Next, what is the baby's respiratory drive? And again, in this particular case, as I pointed out, the baby had no spontaneous respiratory effort and had a very high serum magnesium level, which, as you know, is a strong respiratory depressant. So the likelihood is that this baby is going to need a higher level of support than if the baby were breathing 60 or 70 times a minute on his own. And this will help us make an educated guess about where we should set the rate on the mechanical ventilator. And finally, I asked myself, what's the primary problem that the baby is having with respect to gas exchange? Is the baby having mostly problems with oxygenation, mostly problems with ventilation, or is there a combination of the two? And again, this will help direct how I set up the ventilator for this individual baby. Now, all of you are well aware that there are many options available to us now to treat babies who have suboptimal respiratory function at the time of birth. And although there is a very large swing of the pendulum towards non-invasive ventilation, and in some places, very sick babies who are ultimately started on high-frequency ventilation, I'm just going to concentrate now on babies who have lung disease severe enough to warrant mechanical ventilation, and I'm going to address only conventional or tidal volume ventilation. I'd be happy to talk about continuous distending pressure or high frequency, but we would be here for the end of the week. So the second rule then is to pick a target variable. And here by that I mean either selecting a pressure-targeted mode of ventilation or a volume-targeted modality of ventilation. And because I'm going to talk more about this in my next presentation, we'll skip over it fairly quickly. Among pressure-targeted modalities are pressure-limited ventilation, and I think there are still a number of ventilators that are in use that provide pressure-limited ventilation, or more currently, pressure control ventilation. The main feature of both of these is that you, as the clinician, tell the ventilator what peak pressure you want to be delivered, and the ventilator will stop the breath when that pressure has been reached. The main problem with pressure targeting is that the delivered tidal volume will then be dependent upon the baby's compliance. And if there is a significant change in compliance, there may be a significant change in volume delivery unless you're at the bedside and can adjust very promptly. And we'll talk more about that in the next hour. Volume targeting is kind of the inverse. And here you select a tidal volume or a delivered volume that the baby will receive, irrespective of the amount of pressure that it takes to deliver that volume. So volume is constant, and pressure will fluctuate according to compliance. And we'll again describe this more fully later. Now, I'm often asked, you talk about volume targeting. We don't have a volume targeted ventilator. How do I know if I'm setting the right pressure to deliver an appropriate volume of gas to this baby? Now, I'll draw your attention to the graph on this slide, because what we're trying to do, remember, if this is our theoretical pressure-volume relationship, or static compliance curve, what we want to try to do is to ventilate the baby at the steepest portion of this curve. And if we define compliance as the slope between the origin of the graph and its peak inspiratory pressure, this compliance line, as you can see, will be steepest at the mid portion of the curve. So if we're ventilating with too high a pressure, we're in the zone of overexpansion and potential lung injury. And you can see that our loop is bending at the top of the curve towards the right. Now, conversely, if we're ventilating down here, we're not giving enough expansion to that lung. You see how flat our compliance axis is, and this is in the zone of atelectotrauma. So both being too low and being too high increase the risk of ventilator-induced lung injury. So we want to try to adjust our pressure or our volume to provide a tidal volume that is somewhere between 4 and 7 milliliters per kilogram. And it's going to vary depending upon the individual mechanics of the baby's lungs. And again, our goal is to try to avoid both hyperinflation and underinflation. And finally, the take-home message here is that a happy baby will breathe at roughly 40 to 60 breaths per minute, provided there are no confounding factors like a high magnesium level or a high morphine level. If the baby has relatively little sedation and you've set the tidal volume appropriately, the baby's respiratory rate is going to be in a normal range. If you're underventilating the baby, your tidal volume is inadequate, the baby will breathe more rapidly to try to compensate and maintain minute ventilation. And conversely, if you are overventilating the baby, if you've taken away the baby's CO2 drive, what's going to happen? The baby is just going to lay back and let the ventilator do all the work. So following up your ventilator adjustments by going to the bedside and giving a close observation of the baby is really important. And number 3 is to select a mode of ventilation. Now, a mode of ventilation refers to how the ventilator interacts with the baby, how it provides mechanical breaths relative to the baby's own spontaneous breathing. And for many years, perhaps a quarter of a century, the only thing available to neonatologists was the old-fashioned IMV, intermittent mandatory ventilation, or as I used to call it, independent mechanical ventilation. Why? Because the clinician set the ventilator to do what the clinician wanted it to do, and the baby breathed based on what the baby wanted to do. And if we got synchrony, it was strictly by luck. And you can see that on this graphic description. Here in each of these panels, you're looking at ventilator flow, airway flow, and pressure. And with intermittent mandatory ventilation, you see that the breaths are delivered, in this case, exactly 2 seconds apart. So the clinician has said, has programmed the ventilator to cycle at 30 breaths per minute. And every 2 seconds, the ventilator delivers a breath to this baby. In between, occasionally, you see the baby makes a spontaneous effort that is supported only by the positive end expiratory pressure. And unfortunately, with intermittent mandatory ventilation, the risk of patient ventilator asynchrony or dyssynchrony is very high. And you can imagine what might happen if the baby is trying to exhale at the same time the ventilator is trying to provide positive pressure. It's not a good situation for gas exchange, and it's been associated with significant morbidity, including an increased risk of intraventricular hemorrhage. The first breakthrough came with the development of synchronized intermittent mandatory ventilation. And when you compare these two graphics, they're very similar, but there is a subtle difference. And you see that the mechanical breaths are not spaced exactly 2 seconds apart. And even though the ventilator here is set again at 30 breaths per minute, you can see that these breaths are 2 seconds apart. These two breaths are not. They're closer than 2 seconds apart. Then there's a gap that's longer than 2 seconds. And what happens with synchronized intermittent mandatory ventilation is that within a certain timing window, the ventilator will look for some measure of spontaneous breathing, and we'll talk about that later as well. And if the patient takes a breath within that timing window, the ventilator will initiate the mechanical breath. So at least we can synchronize the onset of the patient's breath with the onset of the mechanical breath and decrease the level of asynchrony. But there's still the same problem that in between, when the baby is locked out from triggering the ventilator, you see that there are some feeble spontaneous breaths that are only supported by the level of positive end expiratory pressure. The final piece of the puzzle was solved in the early 1990s when we developed assist control ventilation. And with assist control ventilation, each time the baby makes a spontaneous effort that exceeds the trigger threshold, the ventilator will provide a breath that is exactly matched to the patient's own effort. And you can see in this case how the baby and the ventilator are completely synchronized and the breath is fully supported. Sometimes the baby breathes at a regular rate, sometimes the baby slows down, sometimes the baby breathes a little bit more rapidly. But the ventilator will follow the baby. And if we synchronize expiration, which we'll talk about in a second, we can have 100% synchronization between the baby and the ventilator. So in essence, now, instead of the clinician guessing what to do for the baby can tell the clinician exactly what he wants. This leads me into a discussion about cycling mechanisms, and that's now an option that clinicians must decide on most present-day ventilators. And there are two ways of cycling a breath. Number one is the old standby time. And when we had the old baby bird machine, as I mentioned before, we go to the ventilator and we would dial in either an inspiratory to expiratory ratio or a specific inspiratory time. And what happens with time cycling is if you say to the ventilator, I want the inspiratory time to be a half a second, when the breath begins, the pressure is delivered to the baby, and exactly after a half a second, the exhalation valve opens and the breath is discharged. And time is on every ventilator. It's also the backup system for the alternative way of cycling the breath, and that's by using airway flow. Now, let me explain how this works because I think it's a very important concept both for efficacy and for safety. Now, this may be a little bit difficult to read, so I will walk you through it. First, I want you to pay attention to the solid line. And what you see on this graphic is one ventilator breath delivered to the baby. And if you remember, our flow waveform has 4 components. We have accelerating inspiratory flow, decelerating inspiratory flow, accelerating expiratory flow, and decelerating expiratory flow. Now I want you just to concentrate on the inspiratory side of this cycle. So again, if you were time cycling this breath, you would go to the ventilator and you would select a specific inspiratory time. And again, let's arbitrarily choose a half a second. So what would happen when the breath began is there would be a rapid acceleration of airway flow. It would peak at some number that the ventilator refers to as 100% peak inspiratory flow. It would then decelerate until it got to the zero flow point at 0.5 seconds. The exhalation valve would open and the breath would cycle into expiration. Now, what happens with flow cycling is a little bit different. And here, what we're going to do is pick some arbitrary point near the very bottom of our decelerating flow. For most neonatal ventilators, this is usually somewhere around 5 or 10%, occasionally 15%. Each manufacturer has a slightly different algorithm. But what happens with flow cycling, again, is the baby begins the breath. There's rapid acceleration of inspiratory flow, which peaks at 100%. It then begins to decelerate. But rather than coming all the way down to 0, that breath will end at a termination point chosen either by the clinician or the ventilator and cycle into expiration directly. So the baby doesn't get the last 5 or 10% of inspiratory flow. And why would we want to do this? Well, there are 2 reasons. First of all, we can again achieve 100% synchrony. Why? Because the baby's going to trigger the ventilator, so he tells the ventilator when the breath is to begin, and then the ventilator knows that the baby is about to stop his own effort close to this 100% line, so it terminates the breath at the end in accordance with the baby's own lung mechanics. So the baby is both initiating and terminating the breath. The baby is controlling the length of the breath. The second reason is primarily for safety. And again, if you're using assist control ventilation, what happens if the baby starts to breathe more rapidly? Well, because you're going to end up with flow initiation and flow termination in flow cycling, the more rapidly the baby breathes, the shorter the inspiratory time will become. Now, this is important because if you were time cycling, the opposite would occur. As the baby breathes more rapidly because you have a fixed inspiratory time, what happens to your expiratory time? It gets shorter and shorter and shorter. So the risk of gas trapping, the risk of inverting the inspiratory to expiratory ratio would be very high. But if you're flow cycling, every breath will be terminated as a percentage of your peak inspiratory flow. So although your inspiratory time will shorten, your inspiratory to expiratory ratio will remain physiologic. Number 5, we'll come back to, I'm coming back to this a little bit, is you still need to choose an inspiratory time or an inspiratory time limit. And again, here, your primary consideration is the respiratory time constant. So knowing what your compliance is, estimating your resistance, can tell you whether you need a short, a long, or an intermediate inspiratory time. And the key here is that you want to leave enough expiratory time so that the baby is able to empty the lung with each breath and not get into inadvertent PEEP or gas trapping. And this slide just shows you what happens. Here, this breath is being time cycled. and the inspiratory time chosen is too long. You see what happens. We're getting a plateau in our tidal volume delivery, and you see that although the breath ends here, the exhalation valve doesn't open until this point. So the baby is really receiving too long a breath with too much volume. And over here, the last 4 or 5 breaths, we've switched to flow cycling. And you can see how it changes the contour of the flow waveform. Here, instead of having this prolonged zero flow state, we cycle directly into expiration when we reach the termination point. And that leaves us with a much more physiologic delivery of tidal volume. Now, this is just an arithmetic demonstration of the time constant. And as I mentioned, the equation to determine this is compliance times resistance. And you see that compliance is typically in milliliters per centimeter of water, resistance in centimeters of water per liter per second. So when you multiply these out, you're left with a number, a time number. And the time constant is the time necessary for a 63% of pressure equilibration. And you need to have at least 3 time constants to achieve a 95% equilibration point. So this is the number that you really want to shoot for. You could go longer than that, but again, even if you went up to 5 time constants, you're only going to get a little better equilibration number. And again, this is very useful in selecting the inspiratory time on the ventilator. And here it is graphically. You see that by the 1 time constant will give you a 63% equilibration. 3 time constants will get you up to 95%. And if you really want to be exact, 5 time constants will get almost a complete equilibration. And here is just an example. A 1 kilogram baby with a tidal volume of 4 who is on that mythical 20/4 pressure. It shows you here that your time constant ends up being 25 milliseconds. So 3 time constants is 75 milliseconds. 4 time constants would get you up to 100 milliseconds. And here is what happens. 2 days later, the baby has received surfactant, is now getting a larger tidal volume. Compliance has improved. We've been able to reduce the peak pressure from 20 to 15, so our delta P is now 11. Our resistance is 100. What has happened to the time constant? Okay, and what should you do to the ventilator settings? Okay, well, what's happened is the baby's compliance has gotten better, the time constant has gotten longer. Now you need to increase the inspiratory time. Rule number 6 is adjusting the PEEP. Now, this is the audience participation part of the presentation. So let me ask by a show of hands, how many of you, when you select your initial ventilator settings, and keep our small baby with RDS in mind, how many of you start with a PEEP of 4 centimeters of water? Raise your hands. Come on, more of you do that. How many use 5? Okay. And how many use 6? Okay, you are my perfect audience. Number 1, you're all wrong. Okay. And number 2, you've proved that you have proven that Gauss lives, because you were a normal distribution. A quarter of you said 4, half of you said 5, and a quarter of you said 6. Okay. Now, why are you all wrong? You're all wrong because you choose the same setting for every baby. And every baby is different. Every baby has a different opening pressure. Every baby has a different set of pulmonary mechanics. So your mission is to find whether 4, 5, or 6, or maybe 7 or 8 is a better PEEP to start your baby. And here is, again, I'm coming back to my basic tenet is that one size does not fit all, and your goal is to optimize inflation. So you want to find the PEEP for the best compliance. And here's the example, okay? First, I want you to look at the solid black line. And what you see here is that as the breath begins at a very the clinician has chosen a very low PEEP, that for a very long period of time, we are not recruiting any lung volume until we get to this point right here, and then we're able to recruit lung volume. And conversely, as we come back down the deflationary limb, when we get to that closing pressure, you see that the lung rapidly deflates. Now, by simply increasing the amount of end expiratory pressure, so if we go from 2 to maybe 6, you see the difference on our dotted blue loop, that the lung mechanics here are much better. We have a higher compliance access. We're getting much more volume delivery at a much lower pressure. This breath is being ventilated at the FRC, as I showed you earlier. So yes, it's a process of elimination, but your ventilator and your graphics can guide your selection of the optimal PEEP for that particular baby. Number 7, if you're using pressure-limited ventilation, how do you set the bias flow in the ventilator circuit? And there are a couple of ways you can do this, but the main thing that you want to do is to avoid something that I called a number of years ago rheotrauma. You know, you've all heard about volutrauma and atelectotrauma and barotrauma. There's another trauma that goes along with this, and that's rheotrauma. And what this refers to is injury to the airway or the lung if your flow delivery is not set appropriately. And if you set flow delivery too high, two things may happen. Number one is you may develop turbulence. And turbulence is not the best means of flow in order to affect good gas exchange. You want to have laminar flow, not turbulent flow. And secondly, if more gas goes into the lung than comes out, in addition to gas trapping, you may develop inadvertent PEEP. And this can interfere with both gas exchange, and if it's too high, can actually impede venous return to the heart and cardiac output. On the other hand, if you set the flow too low, you may create a condition called flow starvation, where the baby is really suddenly starting to tug to try to get more volume. And you can recognize this because the baby is not reaching the peak inspiratory pressure that you have set, or you may not get the delivered tidal volume. In fact, if you're using an older machine that has the aneroid barometer, you'll actually see the needle being sucked into a negative direction because the baby is trying to compensate for inadequate flow. And the graphic I've shown you here is displaying inadvertent PEEP. And here, the clinician originally set the flow in the ventilator circuit at 8 liters per minute. And you see the red pressure volume loop is beginning to bend or beak at the end of inspiration. And this baby has reached the zone of overdistension and is at risk for sustaining lung injury. And simply by decreasing the ventilator circuit flow from 8 liters to 5 liters, you can see how we've normalized this loop and we're no longer overdistending the lung. Okay? And I think the way to remember this is the definition of flow. Flow is the time rate of volume delivery. So by decreasing the flow, you're also going to decrease the volume. Number 8, choose a ventilator rate. And I think even in my own unit, this is the biggest mistake that I see my residents and fellows doing when they're first learning how to manage a ventilator. The big problem that they often do is they set the ventilator rate too high. All right? Now, in the baby I presented, who is significantly depressed from magnesium, that baby's going to need a higher rate because he simply isn't going to breathe on his own. But if you have a baby who's exhibiting a spontaneous ventilator rate of 30 or 40, why would you want to set the ventilator at 50? You'll discourage spontaneous breathing. So what I try to do is find the lowest rate that I can get by with and allow the baby to breathe spontaneously. And I'm often asked, well, what's a safe rate? And obviously what you don't want to see is a baby who gets inadequately supported if he suddenly becomes apneic or has a lower rate. But you know, ventilators, cardiorespiratory monitors, pulse oximeters, they all have alarms. So if that baby suddenly has a less than adequate respiratory drive, you're going to find out about it in a hurry. Okay? So I provide an adequate safety net, meaning if the baby went completely apneic, what rate would I feel comfortable with? And one of the things, if your ventilator is able to do this, you want to follow minute ventilation if possible. Minute ventilation is the product of tidal volume and frequency. And a normal minute ventilation is between 240 and 360 milliliters per kilogram per minute. Now on this graphic, I show you what happens if the ventilator rate is too high. This baby is demonstrating gas trapping. And how you can tell that is if we look at any one of these flow waveforms, here's our accelerating, our peak, our decelerating inspiration. Here is our accelerating expiratory flow. But on our decelerating expiratory flow, look what happens. The next breath begins before the expiratory flow has reached the baseline. So each time this baby is being ventilated, or each time this baby takes a breath that's being supported, more gas is going into the lung than is coming out. Rule number 9 is adjusting the trigger. How many of you are using some form of patient-triggered ventilation? Raise your hands. Okay, quite a few of you. The key here for me is to try to set the trigger, at least in the beginning, when the baby is quite ill and has increased work of breathing, set the trigger at the lowest level that avoids autocycling. Make it easy for the baby to trigger the ventilator. Now, if you go too low, you may encounter autocycling, which is demonstrated on this graphic. And what happens with autocycling is the ventilator is misreading the change in airway flow as patient effort. And autocycling can occur if there's a leak. Autocycling can occur if there is excessive condensation in the ventilator circuit that moves back and forth and creates a flow change. The way that you can determine that this is autocycling is several ways. Number one, first recognize it. You see that on this ventilator, all patient-triggered breaths are in yellow as opposed to machine-triggered breaths, which are in red. Secondly, every one of these breaths is exactly the same. And what you might confuse this with initially is a baby who's just breathing very, very rapidly. Well, even babies who breathe at 75, 80, or 90 breaths a minute are going to have some variability in the rate. So you may see a cluster of fast breaths, a slight pause, then another cluster of fast breaths. You almost never see a pattern where every breath is exactly the same. What you can do, number one, is you can change your assist sensitivity trigger to a higher level and see if it goes away. And at the same time, you want to have somebody going over the ventilator circuit and all the connections to make sure that there isn't a leak present in those areas. And finally, the last commandment, wean from mechanical ventilation. I think all too often we get too complacent. We put the baby on the ventilator, things are going really well, and we're very reluctant to want to decrease the level of support. But if you think about weaning, what is weaning? It's a process in which we transfer the work of breathing from the ventilator to the baby. There's an old saying, I don't know if you use it here in Ukraine, but we use it at home a lot. We say that discharge planning from the NICU, from the neonatal intensive care unit, begins at admission. And I think there's a parallel for mechanical ventilation, and that is weaning, or at least the consideration to wean, should begin as soon as a baby is intubated. Again, another common mistake I see by the inexperienced house officers is they have the baby on the ventilator, they get a blood gas, the blood gas comes back and it's normal. And the resident will turn to the nurse or the respiratory therapist and say, the gas is normal, no change. Okay? What he should be saying is, the gas is normal, let's challenge the baby and decrease the support a little bit. If you take the approach of the gas is normal, no change, the baby will be on the ventilator until high school. Now, there are some physiologic essentials that we need to recognize that if these aren't met, extubation is likely to fail. So number one, the baby has to have reliable respiratory drive. Even if you're going to extubate the baby to some form of distending pressure like CPAP or high flow nasal cannula, that baby still has to be able to breathe spontaneously. The baby has to have neuromuscular competence. You know, there's a signal that originates in the brainstem and the medulla that gets transferred through the phrenic nerves to the diaphragm, and the baby forces the baby to breathe. So that pathway has to be intact. And finally, there has to be a reduction in the respiratory system load so that the baby is able to adequately, spontaneously breathe against whatever increased work of breathing is present. Now, there are also a number of impediments to successful weaning that we can recognize: infection, neurologic dysfunction, or neuromuscular incompetence. We see this particularly with the higher grades of IVH, intraventricular hemorrhage, and periventricular leukomalacia. Inadequate caloric intake. If we're not getting enough calories into the baby, if we're not giving enough fuel, the baby is likely to fail extubation. But there is a converse to this as well, and that is sometimes in our haste to get enough calories into the baby, we overdo the fat and carbohydrate intake. And if you remember, the end product of metabolism of fat and carbohydrate is carbon dioxide. So we may produce more carbon dioxide and therefore increase the burden of breathing for the baby. Electrolyte imbalances and metabolic alkalosis. These are most commonly seen in babies who've received chronic diuretic therapy, and that's a whole nother talk. Congestive heart failure, usually seen in the presence of a hemodynamically significant patent ductus arteriosus with left to right shunting. Anemia. If you don't have adequate oxygen carrying capacity, you increase the burdens of respiration. And finally, the presence of pharmacologic agents which can depress spontaneous breathing, particularly narcotics and sedatives and analgesics. Now, I'll close with another bedside observation, and that is what's happening to spontaneous breathing as the baby's disease process is getting better. And this was the observation that we made. This goes back about 20 some odd years, but here was a brief trial of SIMV, synchronized intermittent mandatory ventilation, which we did in order to assess spontaneous breathing. And here are the mechanical breaths, and you can see that each of these is generating a tidal volume of roughly 20 milliliters. Here are the baby's spontaneous breaths in between the mechanical breaths, and this breath is only generating 5 milliliters of tidal volume. So the baby's spontaneous breathing is roughly only 20 to 25% of what the mechanical tidal volume is. And when we came back several days later and repeated the observation, you see now that The spontaneous breaths are up to 16 milliliters, or about 80% of what the ventilator was providing. And we used this to devise what we called a minute ventilation trial. And this was a multi-center trial done between our unit in Michigan and our sister unit in Middlesbrough in the United Kingdom. We looked at 64 infants who had been mechanically ventilated, and we applied this minute ventilation trial and found that we were able to successfully extubate 55 of the 64 infants. In other words, 86%, we were able to successfully predict extubation for longer than 24 hours. And it didn't really matter whether the baby was greater than or less than 1,250 grams. These numbers were fairly consistent, and they were the same on both sides of the Atlantic. So we felt pretty comfortable utilizing this as a method of determining readiness for extubation. And we then subjected this to a randomized clinical trial where the caretakers were randomized to either extubate a baby according to the minute ventilation trial or according to clinical perception, clinical judgment. And again, it was a prospective randomized controlled trial. There were 42 infants with RDS, and when they had reached 40% oxygen, peak pressure of 16, and a mean pressure of less than 10, they were randomized to either the minute ventilation trial or extubation by clinical judgment. And here were the demographics. I won't spend time on this. The two groups were identical. And here were the results, that waiting for clinical judgment, in other words, you feel like the baby is ready for extubation, took 36 hours. Had a good success rate of 91%. By utilizing this minute ventilation trial, the average time to extubation was only 8 hours, and that difference was statistically significant. The success rate here was a little bit lower, but that difference was not statistically significant. I will close with one of my favorite quotations. You'll find this if you read my chapter in the Fanneroff Martin Walsh textbook. The biggest reason for failure to wean is failure to wean. Weaning should be an active process, and as I said, should begin as soon as you put the baby on the ventilator. If we are going to minimize lung injury, one of the keys is going to be minimizing the duration of mechanical ventilation. And although we may not be able to keep everybody from being intubated and mechanically ventilated, we certainly have the ability to shorten the duration of mechanical ventilation. So I hope I've addressed some of the issues. My main goal here was to again emphasize that every baby is different and every baby needs a slightly different approach. And if I haven't parted the waters of the Red Sea, at least I hope I've given you something to think about. Thank you.
Of successful winning, to be or not to be. I mean, use drug for mechanical synchronization or not. If I use drug, I relax, take off my shoes, give cocktail, and observe my baby. Is everything okay? I control all parameters of ventilations. And in other situations, baby not synchronized, unadjust parameters. It's very difficult to go aside for these babies. What do you say?
Well, I think you're right that some of this really depends upon having an information level that guides your thinking. And if you're using an older generation IMV machine, the principles are still there. It may take you a little bit longer because you don't have the data at your fingertips. But I would also, and I think you may have alluded to this, we're very firm believers in the use of caffeine, both in stimulating babies to breathe early on and to maintain them after they've been extubated so they don't develop post-extubation apnea.
In this question, I wanted to ask one question too. What do you think about using caffeine during mechanical ventilations? Is it recommended or not?
Oh yeah, as I said,
Is the first step when you started ventilations? I use caffeine. It's very nice. Yeah.
we use caffeine. We started on day one.
Thank you.